Dear friends, in this lecture, I'm going to talk about the importance of precision medicine in intensive care practice. It is a common experience for most of us that despite having many similarities, many times the patients don't respond to the treatment, or we are unable to prognosticate the patient, or our prognosis goes wrong, or there is a therapeutic failure. So that keeps us often intrigued, and this difference it causes more of an enigma that why the targets are missed despite so much of similarities. Precision medicine is just an exploration in the science of missed targets, and as Sigmund Freud had said, that do as much as possible for the patient, but as little as possible to the patient. Now, to achieve its end, truly in critical care, it is very important to know that what commonalities and what dissimilarities are there in the same group of patients if they're further segregated on the basis of classifications, subclassifications, and subtypes. Now, this is what is achieved in precision medicine. Although this precision medicine has undergone tremendous development in the recent times, especially in the past few years, the concept of precision medicine is not that new. It is old, as old as William Osler had noted once, that it is much more important to know what sort of a disease what sort of a patient has a disease than what sort of a disease a patient has, where he wanted to highlight that the nature, the various comorbidities of the patients, the ability, the immune mechanisms, etc., can have a bearing on the disease, and that can influence the course of the illness. Now, exactly on same lines, precision medicine also tries to explore with the aid of the various omics as well as the other conventional parameters as though as to investigate those differences that can influence the course of illness, either in terms of the disease prognosis or in terms of their response to therapy. So the term refers to tailoring the treatment to a subpopulation of people who differ in their susceptibility to develop a particular disease or response to a specific medicine. Let us try to understand with some examples. A 25-year-old male of acute febrile illness for 4 days develops shortness of breath with hemodynamic instability, responds to NIV, the shortness of breath, successfully weaned in over a period of week and recovers over a period of 2 weeks. We'll just shift the situation to another patient where a 40-year-old male, again with acute febrile illness of 3 days, develops hemodynamic stability without a fall in saturation, but requires inotropes and vasopressors. But despite inotropes and vasopressors, the patient progresses to multi-organ dysfunction in the next 2 days and leading to acute renal failure, requiring renal replacement therapy for a day, and finally to succumb to the illness. Now, this progressive course of the illness varies in the two patients despite the similar nature of illness because of the differences in their vulnerability and response to therapy. Now, in order to understand this precision medicine, we have to understand a few technical terms and what they imply. For example, phenotype. Phenotype is a clinically observable set of clinical features. And this is important for syndromes like the ARDS and the sepsis, where we get a constellation of signs and symptoms which are clinically observable. So therefore, they constitute the phenotypes. Next, within the phenotype, there are subgroups. Subgroups is any set of patients within a phenotype which may be defined using any cutoff. in any clinical variable or measure. For instance, we use the PF ratio, PaO2 by FiO2 ratio, based on the severity classification of ARDS to divide into mild, moderate, or severe. So this is called subgroup. Then another term is subphenotype, which is a distinct subgroup of a phenotype based on a shared set or a pattern of observable properties, which can be reliably discriminated from other subphenotypes. For example, in ARDS, some patients will have effusion, some patients may not have effusion. Some patients will have ARDS with increased compliance, some will have reduced compliance. So all this constitutes as subphenotypes. Third is the endotype. Now, a subphenotype is with a distinct functional or pathobiological mechanisms that may or may not be associated with specific treatment response is what constitutes as endotype. That is to say that in some of these, certain biomarkers like the IL-6 or the IL-12 or the IL-8 or TNF alpha, etc., may be raised. So with the raised, if we combine the phenotype, say the presence of the shortness of breath with a raised ICL, etc. So we may able to ascertain that whether they're responsive to PEEP, whether they're responsive to steroids, or whether they are amenable to, to prevention from multi-organ dysfunction, etc. So endotype tries to look into those traits or those features which remain hidden, and it tries to dig them out. So how it tries to dig them out? I dig them out either by doing the omics patterns, whether it is transcriptomics, genomics, etc., or by looking into the biomarkers. And when we combine some set of clinical characteristics and or biomarkers as a indicative of an underlying pathogenetic mechanism that responds to a specific intervention, then we reach what is called as a treatable trait. So treatable trait is a set of features. So that set of features includes both clinical features, the biomarkers, the other investigations, or accompanied with certain omics-based features, certain genetic point or markers. So that gives us to able to identify the treatable trait. So in precision medicine, we try to reach to the treatable trait by accumulating or coalescing all the informations that we get from phenotypes, subgroups, subphenotypes, and endotypes in a structured way, in a evidence-based manner, so that the response can be, or the treatment can be tapered on that basis of those treatable trait. Now, one question often arises that is it same as personalized medicine or is it different? The terms are often used interchangeably, but the two things are different because personalized medicine is only related to the drug. It tries to improve the delivery of a drug therapy or any preventive care, including vaccines, tailored to the needs of individual patients by using individual's genetic and epigenetic information according to their preferences, beliefs, attitudes, knowledge, and social context. While in precision medicine, the focus is entirely on the optimal care. So one is the drug delivery, and here it is the care. So personalized medicine is a one small area of precision medicine, despite the fact that both are based on the personal profile and both requires genetic and epigenetic information. But precision medicine needs a bit more because it tries to look into the disease susceptibility, understand the clinical course, and after that only prescribe appropriate drugs or therapies in defined subpopulations of the patients. So largely it can, in single sentence, it can be said that precision medicine defines a disease at a higher resolution because it looks the disease from the beginning till the end, and it enables more precise targeting of subgroups with the new therapies. So this is the difference between personalized medicine and precision medicine. Now look into ARDS. ARDS, as we know, is a clinical syndrome. And in ARDS, there can be several phenotypes, and these phenotypes can be based upon information across three domains: etiology, physiology, and biology. In etiology depends upon the initiation of the lung injury, amplifiers of the lung injury, the resolution, etc. The physiology depends upon the morphology, the hypoxemia, the respiratory mechanics, the respiratory drive. The biology will depend upon the systemic host response, epithelial injury, endothelial injury, angiopathy, local host response, etc. Now, when things are retrieved properly in precision medicine, it is possible to delineate the patients in a subgroup that where steroids, antimicrobials, antifibrotics, or drug withholding may be beneficial, or where PEEP strategy, recruitment, prone ventilation, sedation, and analgesia, these may be optimally tried, or where immunomodulation, endothelial protection, epithelial protection, anticoagulation, fluid management, this may be of primordial strategy. So this is possible to know through the precision medicine. So what it means that multiple phenotypes can coexist between and within the domains. So as much as possible, we can try to segregate them. And secondly, that there is a complex interaction between the phenotypes and the true endotypes. So that is captured in precision medicine, and both by biomarkers and by omics-based medicines. And that's how it tries to segregate them into phenotypic presentations within those domains. So the lack of a common presentation implies that patients with ARDS needs to have a phenotypic approach and applied a precise precision medicine approach. So the next question automatically would be that then how to apply precision medicine for ARDS. As intensivists, if we want to practice precision medicine for patients with ARDS, what can we do? One is to identify the treatment responsive subphenotypes. We know certain subphenotypes are there, that some lungs have high elastance, some have high compliance. So those have with compliance, their response to PEEP will be different from those with poor resistance, and so on and so forth. So subphenotyping patients based on mechanistic drivers can help accelerated therapeutic discovery that can place those patients on a different pedestal and help us to create their goals. Next is use predictive enrichment. So now this is again a technical term. So predictive enrichment is to enroll those patients in clinical trials based on pathobiological characteristics that suggest that they are most likely to respond to a particular treatment. If we know that these are the patients we are likely to respond to steroids, so try to figuring out the pathobiological characteristics of the patients who are steroid responsive and enrolling patients with those pathological characteristics into the trials. Next is repurposing drugs. Repurposing drugs means the drugs that have been studied in other populations can be innovative and promising. For instance, much of the immunomodulatory therapies have come from the cancer therapy, the cancer treatment, and especially after targeted therapies. So those pathophysiological mechanisms that are required in cancer patients, for example, the activation of the immune cells which have been uh, immune paralyzed, etc., or try to inhibit excessive immune response in some cases where it's done by the check inhibitors. So similarly, to repurpose those drugs and try to use them in settings where similar mechanism exists. And fourth is personalized supportive interventions like ventilator strategy, fluid strategy. This can be personalized from the patient to patient on the basis of the existing lung condition, heart condition, etc. So if we practice this four or five ways, we can definitely apply precision medicine by which we can select our group of patients who would be amenable to one kind of therapies, or other group of patients who will be amenable to different kind of therapies, etc. But the aim should be to provide personalized care by matching the therapies to subgroups of patients who are most likely to benefit based upon our the classification. Again, sepsis, precision medicine in sepsis. Sepsis is again, we know, a syndrome. And let us see that example that there was a Scarlet in that trial, that sepsis coagulopathy Asahi recombinant early thrombomodulin trial. They did not report a survival benefit from randomized recombinant human soluble thrombomodulin for patients with sepsis associated coagulopathy. However, exploratory study design using observational registry data identified four phenotypes which were having different clinical trajectories, outcomes, and biological signatures. And they were: one, patients with low vasopressor titration; two, patients with chronic conditions and renal dysfunction; three, patients with high inflammation and pulmonary dysfunction; and four, patients with liver dysfunction and septic shock. And subsequently, newer studies after application of precision medicine found that some benefit was observed in the groups 3 and 4, and but although not in 1 and 2, and more studies are underway to identify the endotypes based upon predictive enrichment of patients with features of 3 and 4. Again, let us take an instance of precision medicine in AKI. Most of the time, we find that clinical trials in AKI examining timing of dialysis, intensity of dialysis, pharmacotherapy, and novel biologics have been consistently negative. They find no difference in the outcome, despite having differences in the patients required for RRT, etc., etc. But there is by and large, there is no difference in the outcome. So ANG1 and ANG2 are endothelial growth factors. These have been identified in precision medicine, which have opposing actions. ANG1 stabilizes the vascular endothelium, and ANG2 destabilizes the vascular endothelium. So authors, we know that the VAST trial was a comparison between vasopressin and norepinephrine in septic shock patients, so which showed no difference in terms of the overall outcome. Authors then re-identified the subphenotypes in a random subset of 328 patients from the VAST trial who had measurements available for ANG by ANG1 and ANG2 ratio and IL-8. And once patients were recategorized with AKI subphenotypes, patients in AKI SP1, that is one of the groups which was assigned, that was the less sick group. This group had improved 90-day mortality with early addition of vasopressin compared with norepinephrine. So therefore, you can see how by measuring this ANG1 by ANG2 ratio and the biomarker ILN8, it was able to delineate one subpopulation or one subgroup of patients in which this this early vasopressin can be beneficial. So this is how precision medicine helps in every spheres. And such findings hold the potential to guide clinicians more accurately assessing prognosis of the patients as well as the response to therapy. Now, what are the broad ways to practice precision medicine? One, use diagnostic tests to identify groups of patients based on their illness etiology. Consider patients' lifestyle, environment, lifestyle, and health history for better understanding of the risk factors. Use digital health tools like use AI and machine learning to analyze data and create models that will help predict a patient's response to treatment more accurately. Consider pharmacogenomic testing for a patient, and pharmacogenomic identify the characteristics of the genotypes and that are responsive to certain agents or less responsive, etc. And consider personalized diets based on patients' blood sugar and other factors. So if we consider these few things broadly, we can start practicing precision medicine in all our patients. Now, how has OMIX guided precision medicine? OMIX have brought phenomenal changes in the practice of precision medicine, and it has guided those various innovative approaches in precision medicine that has been very useful and maybe would be more useful even during the coming days. So, gene expression analysis, targeted sequencing, and genome-wide association studies are the three major strategic approaches of omics, which have largely helped the critical care medicine by trying to differentiate sepsis from non-infectious states, by distinguishing molecularly the subtypes of septic and septic shock, all these things, etc. And of course, which drugs would respond to vasopressors, where to apply steroids, etc. So identification of critical illness subtypes points to a growing need to harmonize them with precise therapies. Besides this omics, even non-omics based strategies have also guided precision medicine. Clinical data, serum biomarkers, the vital sign measurements, ventilatory settings, etc., the endotypes which have been identified outside the omics spectrum, and also the response to specific maneuvers like high PEEP, conservative fluid, etc. Even then, we know that this precision medicine has tremendously influencing the clinical research, because our critical care research has taken a different direction for precision medicine. Let us take the example of Monarchs trial. Um, in Monarchs trial, which studied the effects of efelidomab, a monoclonal antibody, or to TNF alpha in the setting of septic shock, the authors hypothesized that this drug would be most effective in patients who had a high baseline level of IL-6, and found that the study population as a whole showed no difference in mortality, but patients with elevated IL-6 realized a modest benefit. So thereby we can say that precision medicine boldly confronts the current practices in clinical research. Again, there is another method of a precision based this trial, which is the registry based randomized control trial, that looks for precision medicine, that tries to fulfill those gaps that arises out of normal research. The TASTE trial examined the use of thrombus aspiration STEMI using this design, and this resulted in substantial cost savings and rapid recruitment, and more accessible resources of biomedical data became available. We also know that in the recent times, there are a lot of emphasis put on platform, basket, and the umbrella trials, which are all variations of adaptive trials. And adaptive trials have a particular value for precision medicine, because they can allow evaluation of multiple biomarkers, targeted therapies simultaneously or sequentially, by adjusting the sample size, randomizing the strategy or treatment dose during the trial on the basis of emerging findings. So this has also largely helped the growth of precision medicine. And heterogeneity within the study population is tackled explicitly, with precise subgroups defined at the outset in these adaptive clinical trials. So adaptive clinical trials has been one of the major ways for which precision medicine has improved. There are certain non-genomic strategies which have also helped precision medicine. Continuous ECG tracings. This record is available and is stored in small data cards. Heart rate variabilities. So all of this have tried to define the disease states and detect dynamic transitions more accurately, and this has also helped the precision medicine. Large data sets which can be conveniently collected and stored nowadays, from where we can derive new genomic platforms, physiological waveforms, they have been the cornerstone of research in precision medicine. So my final take-home message is that the heterogeneous population of critically ill patients may be better described or characterized by multiple subgroups or subphenotypes, and including endotypes. And these subgroups can be then collected, gathered, or structured in a way to understand that who will have a similar outcomes or who can have a dissimilar outcomes. However, subphenotypes may not necessarily be useful when making treatment decisions. Some of them may be useful, some may not be, but as a group, a lot of them are likely to be useful, more likely to be useful. Useful subphenotypes must be prospectively identifiable, must be readily measurable with acceptable operating characteristics. They should be able to provide actionable information to tailor care and predict treatment responsiveness. And they must be consistently reproducible across numerous populations. Now, all of these requires a lot of effort, requires time, and also a good logistic support. But definitely, if all those support is available, precision medicine can bring a sea change in our treatment strategies, particularly to the various syndromes. And as we know that this this famous dialogue from The Godfather, finance is a gun, politics is knowing when to pull the trigger. So same way that it's not that precision medicine would require a lot of finance, but it is important that even we have reasonable amount of logistics, if we know how to practice precision medicines, how to assimilate the similar groups, how to look into the finer differences, then probably we can make the best use of this its practice for critical care patients. It's vital to make decisions based on data and facts rather than preferences or biases. Thank you.